Gastric carcinoma. Gastric carcinoma is of three types on the basis of histopathology: adenocarcinoma, lymphoma, and GIST, or gastrointestinal stromal tumor. Adenocarcinoma is the most common, and it is due to the glandular cells that are present within the stomach. Lymphoma, as stomach is devoid of lymphoid tissue itself, so it only occurs when there is chronic gastritis due to H. pylori that causes the lymphocytes to migrate into the stomach mucosa and form malt. Then there is a gastrointestinal stromal tumor that occurs due to the autonomic nervous system that is present and line the gastrointestinal tract. Risk factors of gastric carcinoma are either due to the food that the person takes or problems with his stomach. Food includes smoked fish and meat, increased salt use, and decreased vegetable diet. Whereas problems with the stomach include H. pylori gastritis, gastroenterostomy that causes the duodenal content to reflux back into the stomach, and gastric adenomas which are initially benign then become carcinomatous, and Menetrier disease in which a lot of mucus secreting cells are present in the stomach lining. In order to classify the gastric carcinoma, there are two bases: depth of invasion, in which the early gastric carcinoma is classified as the one that grows only into the mucosa and submucosa, and advanced when it grows much deeper and below the submucosa. Laurent classification involves intestinal gastric mucosa, in which it is either polyploidal or ulcerated, and diffuse, in which the cancerous cells diffusely infiltrate the gastric mucosa. Gastric carcinoma can metastasize to other areas of the body either through blood, lymph, direct contact with the surrounding organs and structures, or transperitoneally through the peritoneal fluid. There are some interesting names given to the areas of lymph node metastasis. If the gastric carcinoma metastasizes to the left supraclavicular lymph node, it is called Virchow node. If it metastasizes below to the lymph nodes that are located around the umbilicus, called periumbilical lymph nodes, it is known as Sister Mary Joseph lymph nodes. Gastric carcinoma can also spread through lymph to the ovarian lymph nodes, called Krukenberg tumor. It can also metastasize to the pouch of Douglas, which is a pouch located between the rectum and the uterus. There it is called Plummer shelf tumor. Person with gastric carcinoma, like any other cancer, will have weight loss and will look emaciated. His age will be, in most of the cases, greater than 45 years. Apart from it, due to mass in the stomach, the person will have epigastric pain. Mass may be visible as epigastric mass, and there will be bleeding from the cancer when it infiltrates the vessels, which may be occult and seen only in a stool test, or it may be in the form of hematemesis and melena if the bleeding is significant. If the gastric carcinoma blocks the pathway to food, then dysphagia and vomiting can also take place. Along with this, there would be visible lymph nodes, those mentioned before: supraclavicular, periumbilical, ovarian, and the ones in pouch of Douglas, which can be examined by digital rectal exam. In order to diagnose gastric carcinoma, we do gastroscopy, in which we see the tumor itself and we take aggressive biopsies, up to 10 biopsy specimens from it. Then endoscopic ultrasound can also be done to find the depth of cancer invasion into the wall of the stomach. In order to stage the tumor, CT, PET scan are done, and laparoscopy in order to visualize the metastatic implants within the abdomen. Treatment involves 3 steps: surgery, which includes gastrectomy, chemotherapy that uses combination of 3 drugs, epirubicin, cisplatin, and fluorouracil, and palliative procedures in order to help improve the life of patient when the disease is incurable. In gastrectomy, subtotal and total gastrectomy are done. In subtotal gastrectomy, only the tumor containing part of the stomach is removed along with the tumor free margin, and the rest of the stomach is joined to the jejunum, known as gastrojejunectomy. This is done when the tumor is located in the antrum or in areas of that lie in the lower part of the stomach. In case of total gastrectomy, which is done when the tumor is located high up in the stomach and the stomach cannot be salvaged, therefore the entire stomach is removed and is excised away. The esophagus is then joined with the jejunum through esophagojejunostomy. Disease is incurable. We help the patient in feeding. Since dysphagia and vomiting can occur, we pass a tube down from esophagus into the duodenum. This bypasses the obstruction. This is known as intubation and stunting. We can also pass a tube that connects outside to the lumen of the stomach and help the person to feed through it. This is known as a gastrostomy tube. But if the entire stomach is obstructed or we cannot pass a gastrostomy tube, then we can connect the jejunum of the stomach through a tube to the outside, known as a jejunostomy tube. Both these are feeding tubes used in gastric carcinoma. If the gastric carcinoma totally obstructs the pylorus or is located near to it, then we can create a passage between the jejunum and stomach, known as gastrojejunectomy. A 55 years old lady presented to the surgical department with epigastric discomfort, epigastric mass, and hematemesis. On examination, she is emaciated, dehydrated, and anemic. She has an enlarged lymph node in the supraclavicular region. These are the important hints. The most important of them include mass in epigastrium and an enlarged supraclavicular lymph node, also known as virchow node. This means that it is gastric carcinoma.